So good afternoon, everyone. I'm so thrilled and excited to moderate this session for the Joint Academic Ophthalmology activity today with the title of KKH Retinoblastoma presented by Dr. Saleh Al-Mesfer. Um, so we'll talk about the history. We'll talk about the history of retinoblastoma at KKH, a little few slides about that. And it started with Susan Senft, who is a board certified ophthalmologist, and she attended a postgraduate study at the Stanford University, completed a one-year fellowship in fields of pediatric ophthalmology. Actually, it was 2 years of pediatric ophthalmology, anterior segment, including cataract, cornea, transplant, and oculoplasty under the direction of David Payton. I bet you will be surprised as I did that she did that at King Khalid Eye Specialist Hospital in 1993 to 1995. So Susan Snift, she was a clinical assistant. She is a clinical assistant professor at ophthalmology at King Saud University. She has lots of volunteering activities. She's a fellow at American Academy. She is a member of many society, and she was the leader of retinoblastoma at KKH. She has a lots of responsibility, including training residents and fellow orchestrating numerous basic science, clinical research projects, and managing RB patients. At that time, she also founded the retinoblastoma registry at KKH, which we have a very strong and long retinoblastoma registry. Back to our speaker today, Dr. Saleh Al-Mesfer, who is graduated from high school in 1979. He got his bachelor degree from King Saud University in 1984, and he did his resident training program, the joint program, and ended up in 1991. And I highlighted this year because this is the start of his passion, and actually it's more of responsibility towards RB patients. So he trained with Dr. Senft for retinoblastoma, for caring of patients of retinoblastoma, and he felt that this is a national it's a national mission that he had to lead and stand up for it. Since then, he continued to learn about and train and about retinoblastoma from most of the old KKH staff. They are familiar and well known of Dr. Zain Al-Karsioglu and Dr. Imad Aboud. So in addition to many international meetings. And since then, he started his path and take the responsibility of caring and diagnosis, managing retinoblastoma from all over the kingdom. Um, I'm not going to talk about his publications and his how many presentation he did. We could share that with his CV, but I'm going and also I'm not. It goes without saying that the efforts as a clinician, as a physician, as a surgeon, that the care that he give to his patient. And but I'm going to talk about how human he is with his patient, and how humble he is when he treating. He deserved to be the father of retinoblastoma, because he knows every patient, and he interact with them with their families as a friend, not as a physician. Um, so he started the national mission of retinoblastoma, and this, which is a defective field actually here in the kingdom. And we would like to take this opportunity to encourage young generation to go for oncology in different specialty, including retinoblastoma, of course, but not only retinoblastoma, and oculoplasty and anterior segment and different subspecialty. We are in need for young ophthalmologists to go for this field. Before I leave the floor for Dr. Misfer, I would like to acknowledge the great efforts of Mrs. Wafa Ahmed, who everyone know her, especially our patients. She is our oncology coordinator. She joined Dr. Misfer since 2005 and ongoing. She is the mother actually of all RB patients. She knows them by name. They know her very well. She treats them like a family rather than just a staff arranging the clinics and appointments and everything. And she is taking very good care about the RB registry that was started long time ago. So I would like to thank her and thank also Dr. Misfer about all what he's doing for our retinoblastoma patient in the kingdom. And I will stop here sharing and leave the floor for him to start. Thank you.
Assalamu alaikum. Shukran jazilan. Thank you very much, Dr. Azza, for this great introduction. I would like to share with you today our experience of about retinoblastoma at King Khalid Specialist Hospital. And I think that the registry of retinoblastoma at KKISH represent more than 90 or 95% of retinoblastoma seen in the country. As Dr. Azza mentioned, that we need more young people to join this specialty, especially there's a high need not only for retinoblastoma, for ocular oncology. And we need more young people to take this specialty either as a primary subspecialty or as a second subspecialty. And maybe preferable to go with retina people, pediatric, oculoplasty, and anterior segment. After that, I would like to say that we have a great group of retinoblastoma, which represent senior great staff from King Khalid Eye Specialist Hospital and from King Faisal Specialist Hospital and from KSU and King Fahad Medical City. I will not go through the names is on the slide. And I would like to express my thanks and appreciation for Dr. Susan Simft, as mentioned by Dr. Azza. She was the founder of this group for this retinoblastoma services. We, up to date, we have about 999 patients for a total of 1,400 eyes. This is the total retinoblastoma patient seen at King Khalid Specialist Hospital. There are some patients may be seen elsewhere, but there are not so many. Dr. Saad Al-Zahmash seeing some patients at King Abdulaziz University Hospital. And we are seeing...
Excuse me, can everyone please mute their microphones?
And we are seeing majority of the patient. We could see that there is majority of the patient are referred by Ministry of Health referral channels. Majority of the patient are Saudi patients. You could see that about 81% of patients are Saudi patients. This slide of a young patient who is about 22 presented, which is this is maybe the oldest patient with retinoblastoma seen at King Khalid Specialist Hospital. The average presentation and the laterality is exactly similar to what's been published in the literature. And there is no much difference. Majority of patients are unilateral cases, which represent about 60%, and bilateral cases is about 40%. And we have about 9 patients with trilateral retinoblastoma. Majority of the patients presented with leukocoria, which represent about 75%, the seconded by strabismus, but there are some still patients may present with different presentation like cryptosis, pain, red eye, poor vision, cellulitis like picture, or masquerading presentation. For this reason, all kids with masquerading presentation should be considered as retinoblastoma until proven otherwise. And it's preferable to have the opinion of people who are experienced with retinoblastoma at King Khalid Specialist Hospital. We have some interesting finding with retinoblastoma registry. We have about 13 patients with 13q- syndrome. As I said, there's 9 patients with trilateral retinoblastoma. We have 8 patients with a spontaneous regressed retinoblastoma, 1 patient with rhabdomyosarcoma, Down syndrome, neurofibromatosis, and 1 patient developed sympathetic ophthalmia after retinoblastoma was diagnosed and patient enucleated, but luckily we controlled the sympathetic ophthalmia with the oral steroid. Patient with 1 patient seen with retinopathy prematurity and retinoblastoma was also enucleated, both eyes enucleated and turned out to be retinoblastoma. We have 12 patients developed osteogenic sarcoma, and 1 patient with retinoblastoma who presented 14 years after enucleation was discovered to have recurrence of retinoblastoma in his right tibia. For this reason, this disease is very tough, need a lot of efforts, need a teamwork. It's cannot be managed by 1 person or 1 staff. We could see that there is family history. Now we have facing a problem with the 2nd generation. Most of patients who've been treated or cured or ended with enucleation 1 or both eyes, they get married with time, and now we are seeing their new babies. And you could see that these 2 patients, I mean, this gentleman and this one, both are totally blind, and they have new kids, both luckily seen at KKISH and treated on time where the no vision is lost and no enucleation. This gentleman is a musician, and he's asked me if I need any help from him, but I said, thank you, if we need you, we'll ask you later. We could see that there are about 18 patients are twins, and we have the total number of family with positive family history is about 42. The workup of patients with retinoblastoma is known to all the resident and qualified ophthalmologists. We have to do a clinical assessment with fundus examination, slit lamp examination, ultrasonography, MRI, and we didn't encourage people to go for a CT scan since it may expose the child for some radiation. Workup is could be limited just to the clinical examination and assessment, ultrasound, and MRI. The new classification is our practice. This is the old classification. We are not using the old classification, which is called the research world classification, but we are using the new classification, which is A, B, C, D, E. And it's known to most of the residents and fellows who rotate with us or look at this new international classification, which is our reference, and it's our guidance for the success of the treatment. Our goals to manage this patient is to be sure that we preserve the life of the child, be sure that there is maximum survival of the ocular finding, and try to maintain the vision as possible. Try to be sure that the family is aware of what second tumor, and try to make regular follow-up for this patient to detect any second tumor that may develop related to retinoblastoma. We are doing family screening routinely for all our patient family. Genetic testing and screening also is is done for some patients, but not all. But it's our future plan and for this group of patients. I would like to remove my mask because it's maybe block my voice, and I'm just alone in the office. We could see that most therapeutic procedure done for retinoblastoma is enucleation. One of the most important points for enucleation is to obtain a good optic nerve. MRI shows that there is optic nerve thickening or suspicious of the optic nerve invasion. If the optic nerve is not invaded, and you could see the optic disc by indirect ophthalmoscopy, 10 millimeter optic nerve invasion is acceptable. But if there is an MRI finding that is stating that there is an optic nerve invasion, we have to obtain a long piece of the optic nerve. This will reduce the chances for orbital myths and recurrence. Patient who will go for enucleation is those patients with unsalvageable vision, high failure with the current treatment, or non-compliance with the treatment. Sometimes we are forced to go with enucleation. we could see that there's about unilateral patient who ended with enucleation is about 53%. And we have about 65 patients ended with bilateral enucleation. The total number of patients underwent enucleation is 62% of the total 1,400 eyes. Current modality of a treatment available at KKH is transpupillary thermotherapy for all patients with possible success with focal treatment. And the cryotherapy is the second one for some of the tumors. Sometimes we combine the treatment. We do cryotherapy and we combine it with transpupillary thermotherapy, especially if the tumor size is more than what could be controlled with focal treatment with one modality. And I found this modality is very successful and encouraging to combine it in certain sizes. IV carboplatin introduced in 2004 at KKH, and since then we are doing a great by using systemic IV chemotherapy. And kindly we have two pediatric hemato-oncologists, Dr. Muhammad Karawi before and Dr. Rajiv. Now we have Dr. Rola Parmada and Dr. Rajiv. And we are using this modality for all patients who need a combination of IV carboplatin and thermotherapy. And it is very promising and successful modality of treatment. For those patients with vitreous seeds, sometimes we need to give intravitreal melphalan. We introduced this technology and this procedure in 2013. The systemic chemotherapy, we go with a 3 to 9 cycle. It's depend on the size of the tumor, type of the presentation, and the group of the classification when the patient is presented. If there is the tumor is contained and there is no MITs, sometimes no MITs within the vitreous. Sometimes there is no seed within the vitreous. We didn't go for high number of cycles, but if there is a need for more than 3 cycles, we go sometimes for 6 cycles, sometimes we go for 9 cycles, depending on the presentation and depending on the laterality of the disease. As you know, there is what we call it intra-arterial chemotherapy, and the intra-arterial chemotherapy was introduced by Algernon. The first time it was done on 1954, where he used triethylene melanine alkylating agent. And then it was revised. At that time, the procedure was not promising, and it was revised by Yamani and Kaneko in 2004, where they do a selective ophthalmic artery infusion. And what I mean by the selective ophthalmic artery infusion, they introduced a catheter through the carotid artery, and after the exit of the ophthalmic artery, they inflate the balloon where they block the carotid artery, and they then inject the chemotherapy to the carotid artery, and it will go to the ophthalmic artery. And there was a concern if this patient, after this type of procedure, they develop any stroke or any brain damage, but according to Dr. Kahiro Kaneko, none of these patients develop any sequelae with this procedure. Dr. David Abramson revised the procedure, and he go through ophthalmic artery, and he introduced this technique in 2006, where is a French catheter, which is 400 micron, go through the carotid artery and to the ophthalmic artery. And this is a super selective modality to inject the chemotherapy directly to the globe itself. And by this way, you could avoid the systemic side effect of intra-arterial chemotherapy. And the problem with this technique that the age is sometimes as a limitation. Children with less than 6 months, sometimes very difficult to do catheterization. And sometimes there's a lot of variation within the ophthalmic artery, where is about 12.5% of patients. Sometimes the radioneurologist sometimes cannot access the ophthalmic artery. The current medication that could be used for this modality is melphalan, the topotecan, and carboplatin. And this technique was one of the techniques that we didn't have at King Khaled Specialist Hospital, and we cannot do it because we didn't have the infrastructure, and we didn't have the specialist, and we didn't have the technique. For this reason, with availability of more radio neurologists at King Faisal Specialist Hospital, especially Dr. Jyoti, we introduced this technique and we start to do this technique and refer the patient based on some criteria. And we did about, I think it's not 11 patients, this is my mistake, but we did few patients. And it is ophthalmic artery cannulation for intra-arterial chemotherapy implemented with King Faisal Specialist Hospital. And nowadays we are doing this technique for some patients, depend on the presentation, depend on the criteria that we agreed on it with people at King Faisal Specialist Hospital. We found them they're a great group, excellent cooperation, and this technique could help some of our patients. Radiation is not, appropriate management. It was the first line of treatment in the 60s and 1960s. But there was a lot of side effect was encountered with this technology and with this modality of a treatment. And you could see this patient is, totally blind, but he's disfigured because of the radiation. This is a child who received radiotherapy in both eyes, and you could see that there is some dermatitis after radiotherapy. This child is still alive with both eyes. One of the eyes has non-operable retinal detachment, the other eye is the only seeing eyes. The second modality for treatment as radiation is the radioactive plaque. We did about 29 patients at KKISH in the registry. And most of these cases done by Dr. Amada Aboud and Dr. Zikarsoglu. Nowadays, we are not doing any brachytherapy for two reasons. First, most of the patients, they go for chemo reduction and transpubic thermotherapy, which is, we found it very effective. Second, we have logistic problem with King Faisal Specialist Hospital, and we try going to introduce and revise this logistic difficulties, especially for cases with melanoma, and maybe some cases with retinoblastoma may need in the future. For this reason, we are working with people at King Faisal Specialist Hospital to arrange to have the brachytherapy in the near future. The complication of radiotherapy, I will just share with you this slide. Cataract could be seen in about 90%, but this could be, not 90%, 33.5%, and this could be managed easily by lens aspiration and BCIL. For this reason, it's not a problem. The problem that if the anterior segment or ocular surface is exposed to the radiation and patient ended with a stem cell deficiency after the radiotherapy, sometimes these patients may develop retinal vasculitis after radiation and ended with vitreous hemorrhage. Sometimes these patients may develop second tumor, and I will go through this slide. You can see that this is a radiation-induced cataract. This child is an Egyptian child, received the radiotherapy at the age of 3 months in Egypt. And when he was becoming the teenager, his family moved to Saudi Arabia for further work, and the patient was seen at KKISH. And you could see that he's about teenager now, but his face is affected by the radiotherapy and disfigured. They were a twin. He's one of a twin. His brother is doing good, nice looking, but he is not acceptable for him and for others. This child received radiotherapy to his right orbit because of high risk of metastasis from the right orbit mets, and he developed second tumor in his left orbit. The left eye was preserved and was seeing eye, but unfortunately he developed osteogenic sarcoma on the left orbit. If you ask me how many patients survive in this RB surfaces, we have, as I said, you have 999 patients. We have about 783 patients are alive, which represent about 78%. Our diseased patient or passed away patient is about 121, which represent about 12.3. We have about 44 patients lost follow-up and about 51 discharged because the family, they are non-Saudi and they moved from the country. The success rate, if you look at it in Western country, they may report it as 95%, but depend on the presentation. If we look at the patient who presented early without any medicine, without orbital extension, we could reach the same percentage. But if we include all these patients who presented with orbital extension, and metastasis, the first survival rate is not comparable to the Western country. But in my opinion, our success rate is very acceptable and at expectation, but we have difficulties with the families sometimes who may refuse the treatment on time or may present late. If we look at the globe preservation according to the ABCDE classification, you could see that with A and B, we're expected to have 100%, and this is what we're achieving at KKISH. All patients with A and B, I could say that none of them lost their vision or they lost eye because of the treatment or failure of the treatment. For group C, the success rate could reach up to 55, D 15%, but unsalvageable group is 0. If we look at what's the achievement of education that done by this group of patients, I have 4 patients of my retinoblastoma registry that are dentists. One of them is doing a PhD in New York at this stage. We have 1 medical student at Prince Nora University, and we have a lot of them, they have master and bachelor degree. For this reason, this disease doesn't interfere with education achievement. Family screening is one of the important points, especially with the second generation. I mean, as I said, we are seeing a lot of patients who are being treated at KKISH or elsewhere, and they are now get married and they need follow-up for their children. This is a child presented on 1992 with bilateral disease, physical eye, optic nerve is thickened. I am the one who did the surgery for this child. You could see the calcification, how extensive is the intraocular space, and the optic nerve invasion. She was subjected to 18 cycles of chemotherapy after enucleation as an adjuvant. This is 2 slides is for her first kids. They are a twin because she took some stimulating for pregnancy, and I think colomide or something like that. And this is her kids. I mean, you could see that we examined her children at young age. This is a small lesion developed, and we screened all her kids. She got 4. This is a family screening for her kids. You could see all these lesions treated with focal treatment. We didn't need to enucleate the eyes or subject them to any form of chemotherapy or radiotherapy or any form of extensive or destructive treatment. This is, another patient presented with retinoblastoma and his right eye. It is affected. You could see that the 2 big lesions, and this is imminent to seed. This child was treated with IV carboplatin at KKISH and multiple sessions of transplant thermotherapy. And this is the outcome. Disease is totally controlled and just ended with chorioretinal scar. This is another child with retinoblastoma, Saudi. Left eye was enucleated, and the only remaining eye is the left eye. And you could see that the tumor is big with seeding in the vitreous. Patient was subjected to chemotherapy and radiotherapy because there was some external, there's some vitreous seed. And this is a long time ago before we introduced the melphalan for intravitreal injection for retinoblastoma seeds. This is another child presented to us. Left eye was enucleated, right eye was the remaining affected eye. You could see the macula, the lesion, and the optic disc, and this lesion. All the tumor is contained within the retina tissue. For this reason, there is no vitreous seeding. Treated with carboplatin IV given at KKISH, and thermotherapy ended with a scar and normal macula, expected with normal vision. This is another child, Yemeni patient. This is a very interesting case. I would like to go with bilateral. The right eye was enucleated, and the left eye was affected. And this is the big lesion treated with IV. We give him IV carboplatin, cryotherapy, and 5 cycles of carboplatin and thermotherapy. Finally ended with the controlled disease and normal remaining vision since the macula was not affected. This is a child, his father is a teacher from northern area, presented to us with this big lesion, and you could see the subretinal exudate and the macula. And the left eye is the affected, right eye was normal. We treated him with carboplatin given at Kekish and multiple session of thermotherapy, and ended with total control and remained macula looks okay, and ended with vision 20/40. There's another child from Bangladesh presented with this big lesion, and left eye was enucleated. I think by mistake we put it left eye, but one eye is enucleated and the right eye was the remaining. It is the right eye. The right eye was the remaining eye. Treated with carboplatin and thermotherapy, and luckily his eye is preserved and the vision is expected to be normal. This is another child from Yemen, bilateral, both eyes, very huge tumors, and imminent to seed. It was difficult to refer the patient to King Faisal Specialist Hospital for systemic chemotherapy. For this reason, we treated him at Kekish with carboplatin IV and thermotherapy to the left eye and cryotherapy for some lesions in the periphery. And he ended with a good result for his disease, and ended with chorioretinal scars. If we could look at this patient, I mean, you could see that the tumor is too big in the left eye. And it was, we didn't know exactly how could we control the disease. But since we have carboplatin, and Dr. Karawi was so motivated to repeat the cycles of carboplatin at Kekish, we ended with, I think, 5 cycles of carboplatin with thermotherapy. And it was applied to this huge lesion and all the lesion in the left eye. And this is what happened. After the third cycle, I think he developed extensive vitreous hemorrhage. I couldn't see any details. We decided just to observe the child, and this vitreous hemorrhage started to clear up. When he presented to the third visit, the total vitreous hemorrhage were cleared up, but we found that there's an activity within the area, and we treated this one with transpupillary thermotherapy. Ended with total control. The child still comes for follow-up and has no activity in both eyes, and his one of his eyes is good seeing, and this eye maybe the macula is not functioning very well. This is another child presented with this extensive disease, and we could see that the tumor is huge, involving the posterior pole. We treated him with carboplatin, and you could see that the disc is not visible when he presented. This slide was taken from different angle, but if you look at him, this is the posterior pole, treated with carboplatin, 2 cycles, and thermotherapy. This is a child with a small lesion. I mean, if you could look at the slide here, you could say that there's a small lesion here and one lesion here. I mean, this one is an RB lesion. Sometimes we'll not be able to see it without appropriate screening. If you look at the patient as an outpatient with positive family history, just you present the child and you would like to see, you may miss these ones. For this reason, once the patient has a parent affected, we subject them for EUA. We don't look at them in the clinic. But if the parents that are not affected and one of the children is affected, we just do screening in the outpatient. This is a child presented with this lesion, treated with IV carboplatin and thermotherapy and controlled. For this reason, what I would like to say that since we introduced the carboplatin treatment with thermotherapy, we are not using the brachytherapy. And since 2004, I didn't find any reason to go for brachytherapy. This modality is maybe not as needed as before. With availability of the chemotherapy in the 1960s and 70s and 80s, the chemotherapy was not the line of a treatment of retinoblastoma. But then it started by late 80s, 1980s and 90s, the chemotherapy became one of the modality of treatment for this group of patients. I would like to share with you our new approach for treatment of retinoblastoma. Since we introduced the intra-arterial chemotherapy, we have a few patients, referred to Dr. Juti and Dr. Riyad Al-Aqili, at the radiology neurologist at King Faisal Specialist Hospital, where they received milfelan as intra-arterial chemotherapy. And this is a patient presented. You could see the macula, but you couldn't see the disc carefully. This is the slide, same photo, but we took the RITCAM on this side. This is after first cycle. You could see the tumor start to become melting. This is the second cycle, and he developed some vitreous seed where we have to go with intravitreal milfelan injection. This is one of the visits, and this is the last presentation. You could see the disc looks normal, macula looks normal, and the tumor regressed totally. We're still observing that there is a shallow retinal detachment here, and we're still observing the child to be sure that this is just a tractional versus unlikely recurrence. For this reason, this child is still under follow-up, and we saw him this week, and he looks okay. We found that we need to treat his amblyopia in his right eye, and you find that he has a strabismus, where we manage this child with botulinum injection, and the child is on orthoptic treatment for amblyopia. This is the second child who presented with macular involving retinoblastoma, referred for intra-arterial chemotherapy. And he received one cycle. This is after first cycle, after the second cycle, after the third cycle. At this stage, we decided to treat the fishy flesh within the lesion with thermotherapy. This is now the last finding, and we could say that this child has no activity at all in this retinoblastoma lesion. What I would like to stress to the resident and for physician who may see patient with masquerading presentation, that please, all children who may present with unclear history or vague presentation to be considered as retinoblastoma until proven otherwise. We are seeing patients managed incorrectly by different specialties, which may include retina, glaucoma, pediatric ophthalmology, where they are given the wrong diagnosis and either discharged from the patient because there is no visual potential, or patient managed incorrectly. We encountered patient treated as endophthalmitis. We encountered patient treated as retinal detachment. We encountered patient treated as glaucoma. For this reason, please, once patient presented with masquerading syndrome or masquerading presentation, to consider retinoblastoma and try to obtain appropriate consultation from expert people. We are looking for a future project where to go and do the genetic study for all our patients, especially for those who get married, to be sure that they will not have children with the disease. And this need to be done with people from genetics department at General Hospital, where they could go for pre-implantation and genetic testing. We need more educational, and we need to create a national registry for retinoblastoma in the country, where all patients are registered under one umbrella, and to be sure that all these patients receive the appropriate treatment and appropriate follow-up. Second, the tumors and when is very important to be identified on time, because some of these patients may develop second tumor in the form of osteogenic sarcoma, and they may need some intervention. We are facing difficulties with those patients who are not Saudi and not eligible for treatment. And luckily, most of these patients, sometimes they obtain a good royal order for treatment at higher center, especially when they need chemotherapy and adjuvant chemotherapy. I'd like to thank all of you, and hopefully this is a fruitful finding for you to learn. And if you have any question, I'm willing to answer it.
Thank you very much, Dr. Mesfer, for sharing your long experience in managing and taking care of retinoblastoma in the kingdom. And I'm pretty sure that if we segregate the RB registry at KKH, the successful rate for saving globes and saving life is much higher, because this is a general data for both groups. And I'm sure that once the systemic chemotherapy was introduced, and taken into consideration, uh, the successful rate would be much higher. Thank you very much. If anyone have a
I would like
question?
just, if you ask that, let me just comment that uh, it is very difficult to manage this form of this type of the disease without the help of ocular pathologists and pediatric hemato-oncologist and radiotherapy staff and radio neurologist. I'd like to express my thanks to Dr. Azza and Dr. Hendo Kattan because they work hard to establish a very good way to report the histopathology of retinoblastoma, which was not the case before. Now they go through all the detail, all the cuts, and try to be sure that there is no missed part within this nucleated eye to report any high-risk factors.
Thank you very much. I'll open the floor for questions.
Salam. Assalamu alaikum, Dr. Mesfer.
Alan, Dr. Arola.
I want to thank you regarding this very excellent presentation, and I am very proud to be a part of your group for retinoblastoma. But from my experience here in King Khalid and before even in King Faisal, I was observed that they are coming very late. And many times they said that they discovered this leukoria or abnormality in the eye since long time, but unfortunately they are coming very late. For anything to let them regarding education of this population, general population, regarding the retinoblastoma, even for one family positive retinoblastoma, they came late for the child to be screened here. Anything to help them or to guide them or educate these people, even in oncology before. I saw many cases, even the government, she did a very good job regarding this, helping people getting regarding medical care in this country. But I observed that the people they are coming very late to seek the help. Anything to help or to correct these things?
I will just comment on your inquiry. I agree totally with you that most of our patients may be present late, but this is not the case in the last, I could say, 5 or 10 years. This was in 90s and 80s. It was, most of patients, they present late. Nowadays, the facility and availability of ophthalmologists all over the country, qualified consultant available everywhere. For this reason, the presentation of patient to KKH is not as before. We used to see a lot of patients with orbital mids, orbital invasion, distance mids. Nowadays, it's not the same as before. One of the difficulties we are facing is that the non-Saudi patient who may present late and sometimes they are illegally within the country. Sometimes they are afraid from reporting these findings to the governmental hospital because they didn't have an ID, they didn't have passport, they didn't have legal permit. And we are facing a problem with this patient because even if we would like to help them, they didn't have any document to be included in the system. This is one of the problems. But for the Saudi patient, I didn't find that it's any difficulties. Most of our patients Saudi, they are presenting on time. Maybe not as we expect, but at least the survival rate for them is high. The problem is with non-Saudi patients. We are facing some family that are refusing the surgery. And this is a problem. For this reason, Dr. Azza with Wafa, they create a group where all the mothers and family in that group, they discuss all the difficulties. And I think more education is needed. I agree totally with you. Thank you,
Thank
Dr.
you very much. Thank you.
If you may allow me to comment, Dr. Saleh Al-Mesfer, thank you for your input, and thank you, Dr. Rula, for your question. The group is also was the supporting group for the mothers was created with from the social services, and they are taking very good care of the some of the RP patients who volunteer to be part of this. And we are seeing now more mothers, new mothers, that are supported by mothers of children that they pass through this bad experience, and they are very helpful. So I would like also to thank the social service and educational service here at KKH.
What I maybe suggest for the young ophthalmologist, this type of ocular pathology need a lot of efforts. And I prefer to encourage all the young ophthalmologists to take it as either as a primary or second subspecialty. It will be good for those people who are in retina, pediatric, oculoplasty, and anterior segment. We need to have a national, team to care about this group of patients. It's not only retinoblastoma. There are ocular oncology cases within the orbit, melanoma, ocular surfaces for the anterior segment. Doesn't mean that we have no need. We have a lot of needs. And I would like to encourage my resident and fellows to think about this form of training. We didn't have the facility to train them here, but I think they could have the training abroad easily.
Dr. Mesfer, if you allow me, this is Dr. Hind. Thank you first for the compliments regarding the role of the ophthalmic pathologist. Second, this is a great presentation, and I know that you are a very caring physician who, goes beyond the limitations when taking care of your patients. I would like also to comment, even though it's just a general comment, that the longest optic nerve I have ever received was from your cases, the enucleated globes of RB. So you are really doing a great job already. And I do second your encouragement for the residents and fellows to have some training in oncology in general, because we have plenty of patients. The yield and the care for the patients will save globes and will affect lives of these patients. So I wish really to see more people getting involved in this field. I hope so. And Allah يجزاك خير والله. Great job, Allah, Dr. Mesfer. I hope also to utilize or make use of the amount of patients that you have with the data and the stuff that you are doing, especially in relation to the pathology, because you are already following the 8th AGCC classification, to utilize this in more research and show other people, outside this country, the tremendous efforts that we are doing here with our patients. Thank you.
Thank you, Dr. Hind.
Any questions? Thank you, Dr. Hind, for your comment. I think if there's no questions, retinoblastoma, managing retinoblastoma is a teamwork, and we have a great leader, Dr. Saleh Al-Mesfer here at KKH, and we have a great group, including the radiology department. We have great doctors, Dr. Sahar, and other members in ultrasound and different modalities of imaging. They are doing a great job with us. And also, as I mentioned, the social worker, education, and of course, Ms. Wafa, our coordinator. So if we have no questions, I think we can adjourn this meeting. And thank you very much, Dr. Mesfer, for this journey.
Thank you very much, Dr. Azza. Thank you, everybody. Could we conclude our meeting, or we still need to wait for some question if there is any?
I think people start to leave, so we can conclude.
Okay,
Thank you very much.
thank you very much.